The only autoimmune disease that's really more common is rheumatoid arthritis. There's a good 3 million people affected in the US, 90% of whom are women. The typical onset is age 40, but this much younger woman looked like she had it. And what's going on? The immune system is attacking secretory glands in the eyes and in the mouth and in the intestinal tract, which can lead to constipation. Now, the antibody test that everybody was using at the time when I saw her was typically negative in about 40% of cases. So you really do have to do a biopsy. Ophthalmologists are pretty good at doing this, and I've sent a few people to ophthalmologists to get a biopsy. It's just a small amount of tissue. The problem is that 44%, there's a 44% increased risk of lymphoma with this. So I've had a few patients get diagnosed by a rheumatologist with Sjogren's, and then they were told, oh, well, you better watch out because you could get cancer. Your risk is going to go up. I don't find that a very helpful thing to tell somebody or a way to go, but you should know about this. Typical symptoms: dry eyes, also called keratoconjunctivitis sicca, dry mouth, poor taste, difficulty swallowing. Gum disease is really common with loss of teeth. Parotid glands are often swollen. Person can have a chronic dry cough. They complain of vaginal dryness and dyspareunia. They can have weird rashes, non-specific gut symptoms, especially constipation. And there's a huge overlap with celiac disease and gluten sensitivity. We talked about this over the weekend, really important to keep in mind. Thyroiditis is common. So all these autoimmune diseases are overlapping for unknown reasons. Maybe they have a common underlying problem like leaky gut. Certainly that's one of the theories. Other weird symptoms you can have: memory loss, paresthesias in the hands and feet. So it's a weird disease like lupus in that it can cause this wide range of symptoms. I wanted to use this case because keep that in the back of your mind. Look, we're not so overly focused on diagnosis. We're focused on process in functional medicine. But even so, a diagnosis is something you navigate around. Think about Sjogren's syndrome when you see a weird collection like this of signs and symptoms. It mostly involves dry eyes and dry mouth, but not always. So right before seeing me, she was evaluated. A few months before seeing me, she was evaluated by a chiropractor, astute chiropractor, who did a leaky gut test. And sure enough, she had elevated lactulose. He also found that her testosterone was low and her cortisol was high. All not surprising. She's a little bit young for this, but you know, it seemed like something that was worth treating. So he put her on testosterone, progesterone cream. First, she didn't see much of an improvement, but over about 2 years, gradually got better. He also put her on omega-3 fatty acids for the anti-inflammatory effect. He recommended a paleo-type diet with minimal grains, cutting out sugar, all very reasonable stuff. So when she came to see me, she said, you know, I'm still chewing gum all the time. My eyes don't feel like there's sand in them. My joint pains are almost gone. The biggest problem I've got is severe constipation. And I'm just getting over a case of diverticulitis for which she was taking antibiotics. Really, one of her biggest complaints was that her mood was low and her libido was super low. Plus, she felt uncomfortable in her body. Now, she's a dancer. I actually met her in a dance class. And she was a very good mover, very good dancer. And she said, you know, because of this, I don't really feel comfortable in my body. I feel like something is weird with my body. What should I do? So I did an exam on her. Her parotids were not enlarged. Her membranes looked moist to me. They didn't look super inflamed or super dry. So it seemed more of a subjective thing. She did have a lot of stool that I could palpate in her abdomen. She had normal looking joints, nothing was boggy, nothing was hot, her reflexes were fine. I didn't find any rashes. So really not a super contributory physical exam. So here's your polling question. Based on what I've discussed, what test would you get? No right or wrong answer here. But where would you go from here? ANA, first it comes up, certainly a reasonable test. Celiac panel, certainly reasonable. Although I think she's been on a gluten-free diet, so that can throw you off a little bit. CRP, very reasonable thing to get. Stool analysis, maybe. Yeah, could be helpful. Thyroid test, all good answers. Organic acids, maybe is a secondary test. An autoantibody panel, complement, so a lot of really good things. Vitamin D level, zonulin, maybe zonulin antibodies. So yeah, you're thinking about it. You're thinking in exactly the right way. She just wanted some simple things. So here's where I went with it. A CBC, that was normal. Chem screen, normal. C-reactive protein, a little high at 3 milligrams, but not enough to be inflammatory. Or ANA, people suggested that. Her NA was normal. The anti-CCP was negative. I did a serum protein electrophoresis, and you're going to say, well, why did I do that? It's a very, very crude test for acute phase reactions. Okay, so the main reason we do serum protein electrophoresis is in people where we suspect multiple myeloma. So you're looking for that M spike. It's pretty specific and a great screen for that for a person that's got persistent severe bone pain, weight loss, malaise, fatigue, fevers, so non-specific stuff. But it's also used for early diagnosis of autoimmune disease. And that's because the gamma fraction includes C-reactive protein and includes gamma globulin. So it's a very, very crude test. A lot of rheumatologists do it as kind of initial screen. I don't do it that much because it's not very precise. Instead, I went to the Sjogren's antibodies, the Sjogren syndrome A, Sjogren syndrome B, Rho, and LA test. They're negative. Now, I got to tell you, so this, I saw this patient a number of years ago. Since seeing her, we now have an early Sjogren's panel that's been developed, and it can pick up Sjogren's syndrome years before the standard Sjogren's autoantibody panel. So if I was seeing her now, that's what I would do, is I would get an early Sjogren's panel, which has got antiparotid antibodies, anti-salivary gland antibodies, anti-carbonic anhydrase antibodies. So that panel, which not every lab is doing, but it's fairly widely available, that would be my choice. But this is what we had, and this is what we did. Now, these panels are negative a pretty significant percentage of the time. Even the early panel can be negative, but it's not negative as often as the old standard panel. So how did I treat her? None of this will be a surprise. I tried bowel rest. She had just gotten a course of antibiotics. She had diverticulosis, diverticulitis, so rested her bowel, put her on a little bit higher dose of fish oil than what she was on, about 2,200 milligrams a day, a little bit of GLA. You heard from Dr. Fitzgerald how you want to do that, as in combination with the EPA and DHEA. I put her on berberine because of the diverticulitis, L-glutamine to heal her gut lining, magnesium to get her bowel movements moving more regularly, probiotics because she'd been on the antibiotic, St. John's wort and passion flower for her mood. A lot of people kind of abandon St. John's wort and passion flower. But I think they're both terrific herbs, really terrific herbs. Be sure and use a standardized product if you're going to do it. Passion flower is particularly good for people who are chronically anxious. I put her on a little bit of testosterone cream, 2.5 milligrams a day, and DHEA, and then did some lab testing and recommended that she consider doing an elimination type diet. 9 months later, she comes back saying, I'm feeling much better. I'm not needing as much chewing gum. My joints are fine. I'm dancing all the time. My libido got better on the hormones. I'm not taking the DHEA very consistently. I take the testosterone, but not the DHEA. And at some point, she had been persistently dysthymic. So she saw her family doc who put her on paroxetine. It did seem to help. I checked her DHEA sulfate again. It's still pretty low. So I don't think she's taking it very much. Her serum testosterone and her free testosterone, they both come up. They're looking pretty good. And her estradiol is not bad. So she's made some improvement with testosterone. But the DHEA I focused on, I said, I really want you taking that consistently. Why? Well, because of this paper, Influence of Sex Steroids on Sjogren's Syndrome. It's been shown that people with Sjogren's syndrome have low circulating concentrations of DHEA sulfate. Cause versus effect, not clearly known. But this has something to do with the fact that a much, much higher percentage of women have Sjogren's syndrome than men. The hypothesis put forth in this article is that patients with Sjogren's have an insufficient local androgen effect in the secretory glands. And it's not really clear exactly why. It's more of an observation. Okay, here was an actual study. They took 23 postmenopausal women with Sjogren's. They had typical symptoms, dry mouth, dry eyes, and they had either low androgens or low estrogens. They were given 50 milligrams a day of DHEA for 9 months. All of these hormones went up. Their androgens went up, but more than their estrogens. And the whole notion of DHEA, be careful because it gets aromatized into estradiol, and that's a problem. Well, not really. Not really. So what they found in this study is that those DHEA supplements were preferentially transformed into androgens. And there was an overall trend towards a decrease in dry mouth symptoms during DHEA. I'm not saying it's a cure for Sjogren's syndrome. I'm not saying it's the answer, but it seems to be part of the puzzle. And I wanted to bring this up here because we haven't talked a lot about DHEA over the weekend, but I do think it's very useful for certain autoimmune diseases, especially Sjogren's and lupus. And the interesting thing to me is that patients with Sjogren's syndrome and lupus seem to have a much higher tolerance of DHEA. When women don't have these autoimmune diseases, you put them on 5 milligrams of DHEA and they break out in acne, chin hair, breast hair, etc. But I've had women with lupus who are able to tolerate 200 milligrams a day of DHEA without any androgenizing symptoms at all. So there's something going on about tolerance for autoimmune disease. So when we put all this together into an overall schema, you see the box near the top that says immune dysregulation. What's influencing it? Environmental triggers, multiple genes, not just one gene. Neuroendocrine effects. Well, basically that's mind body, chronic stress. And then the sex hormone milieu. All of these things go together to result in dysregulation. And where's that dysregulation occurring? A lot of it is happening at that immune synapse where the antigen presenting cells are interacting with naive T cells. One consequence of that immune dysregulation is that the antigen presenting cells are sending the wrong signals to T cells and B cells. Those B cells can then get overactivated and start making autoantibodies. The autoantibodies can end up making immune complexes. We know in conditions like lupus, which overlaps a lot with Sjogren's syndrome, you get a lot of these immune complexes, which then activate complement. And the result is tissue injury and damage. So I hope we've gone over this mechanism enough times now that you get a sense of the throughput so that it can start at the top with the environment and with influences on the innate immune system. Now let's talk about a second case, another patient who's an active patient. In fact, I just saw her a few days ago, young woman, 23-year-old woman who presented with probable Crohn's disease. So she's 23 years old and she complains of an 11-year history of recurrent abdominal and pelvic pain. She had been seeing her family practice doc, and she complained that her gut symptoms were getting worse. And the PCP wasn't quite sure what to make of it. She wasn't having bleeding. She had some constipation, but no real bleeding, just this dull ache in her right lower quadrant, but it seemed to be getting worse. The patient and her mother did some research and said, I want a stool analysis. The PCP didn't really even know about doing a DNA-based microbial analysis, but agreed to do it, said, okay, fine. Lo and behold, it comes back with an elevated calprotectin. More on that later, but that is a pretty significant marker for gut inflammation. So based on that, the PCP said you need a scope. For reasons I didn't quite understand, she had an upper and lower scope. The upper scope showed normal esophagus. She was biopsied for celiac disease. Yep, that's pretty much the gold standard. Didn't turn out to have any indication of inflammation in her duodenum. Anyway, that's as far as the scope went. Coming from below, everything looked fine in the descending colon, but when they get to the cecum, they see a lot of inflammation, possibly an abscess. The appendix looks really inflamed, and there's a stricture in the ileocecal valve. So they weren't quite sure what was going on, maybe a cecal abscess, maybe appendicitis, etc. After the colonoscopy, she gets a fever, chills, her belly pain gets worse, and she thinks maybe she's got melanoma, stools are dark. So the gastroenterologist orders an abdominal CT, an MRI enterography. This is really a great test, the MRI enterography, for visualizing the distal part of the small intestine. And what they saw is her terminal ileum was thickened, it was inflamed. There appeared to be 2 small fistula in the appendix. And there was also inflammation in the proximal part of the ascending colon. All of this looked together to be Crohn's colitis, but not 100% sure. Because of the fever, etc., the gastroenterologist put her on flagyl, metronidazole. Well, within a few days, she's covered with hives. She's itching all over and she feels groggy and disoriented. She'd never had this kind of drug reaction before. And that was really the only thing that had changed. She had started on some dietary supplements, but the metronidazole was really the only new thing. She did have an allergy of allergic reaction to bee stings, but nothing medication-wise. Past medical history. She was born 7 weeks early. She doesn't remember much else about that. Was she breastfed or not? She couldn't tell me. She just remembers that she started having gut problems when she was 12. It began with nausea and vomiting after fatty foods. She also remembers getting a lot of bloating after certain foods. And she distinctly remembers getting right lower quadrant abdominal pain that would get worse around her period. Somewhere around that time, her TSH was found to be elevated. It wasn't treated though, because it kept going up and down. It wasn't until the last year before she came to see me that she was finally put on thyroid replacement. She had a history of recurrent UTIs for which she took antibiotics. A couple of years before seeing me, she had been scoped because she was having pelvic pain that they thought was endometriosis. Everything looked completely normal. Also, a year or two before seeing me, she'd had a bad pap showing cervicitis, and they thought maybe HPV. So is all this relevant? Something to throw into the mix. So I looked at the stool analysis that she'd had, I think it was about a month before coming to see me. It was negative for fecal occult blood. There were no pathogens that turned up. She didn't have any yeast. She didn't have any protozoa, no blastocystis. The calprotectin was pretty high, 242. Now, calprotectin is a great inflammatory marker, so much so that if you do a stool analysis and the calprotectin is negative, is low, then you can pretty much rule out inflammatory bowel disease. And you can also assume that there's a much lower risk of cancer. So it's a very, very reliable inflammatory marker. Other inflammatory markers included the eosinophil protein X, that was not elevated, and secretory IgA was not significantly elevated. Her dysbiosis score was mildly elevated. A few findings, though, interesting. Her Akkermansia mucinophila was very low. Now, two bacteria that are keystone species that I always look for in DNA stool analysis, Akkermansia and Faecalibacterium prausnitzii, are very important for maintaining healthy balance in the gut. Akkermansia in particular is very important for maintaining a good mucus barrier in the gut because it is constantly degrading and rebuilding mucin. Akkermansia, when it's low, has also been implicated in diabetes because it's involved in metabolism, probably of short chain fatty acids. She had a mild elevation in Prevotella, which is part of the Bacteroidetes phylum. Hard to say what that means. Some Prevotella are normal. Is the elevation associated with IBD? Don't know. She had low ruminococcus. Unfortunately, the lab reported this as ruminococcus species. Why is that unfortunate? Because different species have different effects, and studies on inflammatory bowel disease have shown variants in those species. For example, in Crohn's disease, you tend to see blooms of Ruminococcus navis. But there are other Ruminococcus species that are found to be low with inflammatory bowel disease. So without reporting the specific species, you're a little bit of a loss to know what to make of this. I've read a lot of this literature on microbial signatures in inflammatory bowel disease. And the best we can say right now is there do appear to be distinct microbial signatures with IBD. There is a difference in people with Crohn's disease versus ulcerative colitis, but those differences seem to vary from study to study. So you can't really pin it down and say it's this bacteria, too much of this, not enough of the other. The best you can say is decrease diversity, decrease richness, and that something is off. Her E. coli were reported as normal. This is an example of what I'm talking about. But there are several studies showing that you can have excessive E. coli in inflammatory bowel disease. So how much is normal? Don't know. I think it's important to have this discussion. I know that we talk a lot about the GI stool testing in the gut module, in the GI module, but this overlaps a lot with the microbiome and what's going on with the immune system. So this is an emerging science, and obviously there's a lot more to be learned here. Other tests that I did, white count, it's up in the upper quartile, which tells me your immune system is activated. As I mentioned in my discussion 2 days ago on biomarkers. She's not anemic. Her hemoglobin is 13. Her metabolic panel is unremarkable. Look at that ferritin. That's pretty darn low. She doesn't have any iron stores, so fortunately she's not bleeding because she doesn't have much reserve.